Hello, everyone. We are ready for pharmacology, talking about administration of medications. Several components to this lecture. So it's divided up into more than one section of learning objectives. So let's look at the first section of learning objectives that we'll be going over. We're going to talk about the guidelines for administration of drugs, or actually safe administration of drugs. We're also going to talk about the errors in medication administration that happen, so that you'll be aware of them. Abbreviations with 100% accuracy. We're also adding the how to properly dispose of tablets, capsules, and other types of medication. So jumping right in and talking about the guidelines for the administration of medication or drugs. The very first thing that we have to always consider is the safety of both our patient and the person administering the medication. Now, for the most part, we don't think about the person administering the medication needing to have to worry about safety. But just off the top of my head, there's two things that I can think of. One is preventing the person administering an injection from sticking themselves, right? That would be a safety concern for the clinician or the person administering a medication via injection. And another one would be dealing with things like topical pastes, nitroglycerin paste, maybe that you're applying to the patient. Now, in the past, we used to have to squeeze out from a tube that looked like a toothpaste tube onto a sticky pad that had lines in it, and then where the line was at told us how much we'd be administering. So it wasn't really accurate, you know. It was to extent. So if it was 1 inch that we put on to the like a big giant, looked like a big giant Band-Aid, then we knew how much that administration was. If it was 2 inches, et cetera, and then you put it on the patient. The problem with that is that, you know, you'd always want to wear gloves because if you touched it, then you quite literally feel like your head's going to explode because it works so quickly on the system. You want to make sure you wash your hands and stuff. And not just while you're applying the patch, but let's say you're assisting the patient to get up, you know, or reposition in the bed. Maybe you're changing the linens, or you need to administer an injection into the hip, you know, and you bump up against that, and it was almost just like wax paper that was holding it. Then it would move, and you might get some of that on your arm because you would have gloves on, right? And then in addition to that, they kind of got away from having the paste that you had to put out to now having like a Band-Aid where the medication is already inside, is already dosed, and so that you can lay it on there and then it's sealed on the skin better, whereas it just wasn't like a piece of wax paper over the medication. But you could see how it could be difficult or easy for the clinician to accidentally have a dose of that. And if they had a cardiology problem themselves, then again, very problematic. Policies for your hospital or the agency that you're working with. Now, every different facility or agency, maybe you're working in home health, or you're in a skilled facility, maybe you're in a urgent care, you know, an ER, it doesn't matter. Everybody will have policies and procedures in place. And so you do need to find out what their policies are, and that would be in the training. If you are watching this video not from the standpoint of a clinician, it's important as well to be familiar that these policies and procedures are in place if you're working in compliance and you need to address something or a policy change, and you're asked to be a part of the committee that does that. So again, this doesn't apply just to clinicians. what happens when you give only those medications for which the physician has written and signed an order for, right? We know that's the way it's supposed to be done, but errors happen, right? So if you only give the medication as prescribed when you're doing it with a facility or a hospital agency and everything, then it's documented and it's double checked, right? We'll talk about that. But, you know, the guidelines tell us that we give it only that way. There's never any room for adjustment without it being addressed with the provider. And so we'll talk about that a little more in depth. And also, it is important that if you work in a facility, that you always check with the head nurse or the provider, the physician, when you are in doubt of any medication dose. Don't ever worry. It's not that you're second guessing. So don't ever worry that someone's going to come down on you or correct you. Is if you see something that doesn't look like it should. Maybe it was just written incorrectly. Maybe you can't see the verbiage properly if it's handwritten, even if it is with electronic. Things that are electronic, you know, they're programmed in, abbreviations and stuff are programmed in. Maybe the abbreviation was typed in correctly and it picked up something wrong. So it said, you know, that you're supposed to give it 3 times a day, TID. And in fact, you know, it's a medication that should only be given no more than twice a day, right? Commonly. So again, query the provider, query the head nurse and say, hey, is this actually the proper, you know, dose and administration for this patient? And there may be a reason why that they're being given more, or they may say, no, that you're right, that doesn't look right. Let's go back and check, right? So again, that's part of the guidelines for administration of drugs. When you are dealing with medications now, both in facility and different agencies and stuff, there is a medicine card a lot of times that will be used, especially in skilled facilities. And that information is maybe not electronic yet, right? It could be where you literally scan it and it pops up on the patient's record, and then you're saying, yes, I have administered, I am going to administer at this time, you know, 2 extra strength Tylenol. And then you click on there, the patient's name, scan it, and then the medication, scan it, and then after the patient receives it, you know, you've administered it, then you come back and you scan it again, stating that I gave it to this patient, and you know, it goes from there. Or it could be a card where you literally handwrite everything out, and that's what, you know, we had to do back in the day. But with everything being electronic, it was really nice when we went to the handheld where you could document via the handheld and pick the what you want it to say, and you had little key code things that would give a statement so that it was uniform every time and stuff. But you have to pay attention to the label. Make sure that if you're using a Cardex or electronic medical record, that the medication that you're given, extra strength Tylenol, for example, 2 of them, that is always on there what the patient has been ordered to be given, and that it matches the patient's ID. It's important to always have a backup person available, another nurse or a pharmacist to double check any calculations if you need to change anything. So let's say something as simple as Tylenol, but it's extra strength Tylenol, and they said that the patient could have up to a certain amount of milligrams, and I can't remember. I think, okay, so I don't take this without double checking it, but I'm trying to remember. I think 500 milligrams is an extra strength Tylenol, and 250 is a regular Tylenol, I think. And then, so if they say you're giving up to 1,000 milligrams at a setting, well, if you're worried about the calculation being off, then you double check with the pharmacist and the or the another nurse and say, we have been giving them one, which is 250 milligrams, and the patient is in pain, and we can give up to 1,000 milligrams. So how many? I'm just double checking that this is how many I need to give, right? I usually use ibuprofen as an example because it's always 200 milligrams at a time for a tablet, right? That's a lot easier to do. And aspirin can be 325. It's been a long time since I paid attention to those milligrams and stuff. Do not talk to the patient or other nurses when you're actually administering a medication. That's just poor form. Now we're nice and we're talking and everything, but I can tell you that errors happen, and we think that we're on top of it, but errors happen when you are talking. So stop your mind, focus on what you're supposed to be doing at the time, administer the medication, and then you can talk again, right? Now, if you're needing help or assistance, that's different. But it's poor form to talk while you give a medication, whether it be an injection or oral medication. You really have to be in the moment when you do that. And we get a little lax in that, right? But I can tell you that even as an example for a blood draw, I had that done once when I was in to deliver the number 5 or number 6. I can't remember which one it was. And I have a really good vein in one arm, so I usually always tell them, make sure you draw from that vein. But I was talking to the technician and just jabbering away, and they had just put the IV in my hand. Now, if you're going to be in the hospital for a long time, they usually put the IV up higher in the arm. But, if you're not going to be in there very long, they like to put it in the hand. And they'd put it in my hand, and we were talking and just, like I said, not really paying attention. I offered that arm and kind of had my arm probably covered up and was showing her what a great vein is, and that, telling I used to let students practice on me because I had such good veins, etc. And she came back not even 15 minutes, 20 minutes later, and she said, I have to do another blood draw. I am so sorry. And I said, why? She said, because your blood sugar is 500. I said, or it was like 500, 800. It was really crazy, like, no way. And then we both looked at my hand at the same time and saw that the IV had been placed. Well, it has glucose in it, a glucose strip. And so they were getting pure sugar from my hand all the way up to where she drew that arm. That is not a good thing, right? And so, and why? Because I was distracting her and talking to her. And I kept saying, oh, it's my fault. And she said, no, it's my fault because it's protocol. You never take a blood draw from the same extremity that an IV is in. Basic protocol. And so anyway, attentiveness is very, very important. Another thing that you need to make sure of as far as safety and administration is that your medicine cabinet is always locked. It doesn't matter that if you do or do not have controlled substances in there, it's the fact that it needs to be locked at all times. And you can always tell who the med nurse was on a particular floor for especially for the narcotics and stuff, because she's the one that always had the clanky keys. Also in skilled facilities, because she'd have the medicine cabinet keys, it seemed like. And you're not supposed to give the keys or passwords to anybody that's not authorized. And that even means another clinician. They have to be signed off to be able to have that. Usually it's usually a protocol. And the protocols and guidelines and stuff will change from facility to facility, but these are things you need to be aware of. They're pretty common. There are 6 rights when it comes to drug administration. And when we say right, we mean This is the way you remember that. You make sure first it's the right patient. Number one, Mrs. Susie Jones. Yes. And you notice how if you've ever been in a hospital or doctor's office, they come in and they say your name all the time. And can you tell me your birth date? Yes. It's like I just told the lady that just walked out. It doesn't matter. Every time that person comes in, whether they're a clinician, a technician, a provider, it doesn't matter. They're going to ask you your name, and they'll often ask you your birth date as well. You also need to know the right time and the frequency for administration of a medication. That means that is it supposed to be given in the AM and PM? Is it supposed to be given with meals? Is it supposed to be given only at bedtime? Right? Is it supposed to be given with something like a glass of milk or whatever? And how often? Twice a day, which is BID 3 times a day, TID 4 times a day, QID, QD once daily. Make sure it's the right dose, right? So is the dose 325 milligrams? Is it 200 milligrams? Is it 500 milligrams? It's got to be the right dose. You don't want to get an extra strength Tylenol confused with a regular Tylenol. Right, it's a different dose. And you think, well, Tylenol's not a big deal, but actually, Tylenol can be quite dangerous to a patient, especially if they have kidney issues. Tylenol is, it can be very problematic for them. And ibuprofen, something as simple and as ibuprofen, can thin the blood. So they don't let you take ibuprofen before you're going to have a procedure done, because it thins the blood. What's the route of administration? And we'll be talking about the different routes of administration. Is this an oral? Is this a topical? Is this systemic? How are we getting this into the body? Make sure it's the right drug, right? We keep using Tylenol as an example, and we think that, how can you mess up Tylenol, or why is Tylenol so important? Again, we think of something over the counter not being so important. But there is a difference between Tylenol and acetaminophen. They are the same medication, but one's name brand and one's generic. Is there a reason why? Can you think of a reason why you would use Tylenol versus acetaminophen? Maybe you don't know. It doesn't matter. But if the doctor stated he wants Tylenol given with no substitute, you have to give Tylenol. You can't give acetaminophen, which is a generic, right? Maybe it has something to do with the form that it comes in, a capsule, a pill, a liquid gel. Maybe the person's severely allergic to red dye, and the generic that the provider knows that the generic that you have has a red cover to it, and the capsule that they have does not. It doesn't matter. It's not up to you to know. It's just the fact that the right drug has to be given. Now, if substitution is permitted, then it doesn't matter. But there are reasons that maybe beyond the person administering the medication, and usually stuff like that would be documented, but it doesn't have to be. Your job is to give the right drug. And that means whatever's written is what you give, unless alternatives or substitutes are permitted. And sometimes they're not. The right documentation. So you need to make sure that you're looking at documentation for the current date, right? That there hasn't been any addendums or changes. You don't look at the orders from 2 days ago when you know that an order was given that day, right? Whatever was given that day trumps whatever was written 2 days ago if they contradict each other, right? And because this is the most current order that was given. So this order, the first order may say to give the patient 1 to 2 Tylenol every 4 to 6 hours as needed for pain, substitution permitted. And then the next order that was written for this day could say, give 2 extra strength Tylenol, every 4 hours as needed for pain. Do not allow substitution. Well, it's, again, we can query as to why the order changed, but and it could be because maybe the patient had a reaction to something, and you think, oh, I've never heard of that happening. Well, actually, it does. There's people that are severely allergic to dyes, and sometimes it has to do with glucose, sugar that's in medication, cough syrups that's in medication, alcohol content that's in medication. There could be several reasons as to why a substitution is not permitted. Or maybe the patient just says, I refuse to take anything but name brand, and they don't, and so the provider says, okay, I'll write it that way. And then they know that they're not getting a generic. Again, it could be several reasons, and it's not always any of our businesses to know why. We do what we're told, and we make sure we have the right patient. We're giving the right frequency of administration. It's the right dose. We're giving it the right way, the right administration. So you can't give them a suppository if it's written for tablet or capsules. And if the patient can't take their medication because they've got nausea and vomiting, then you go get another order for a suppository, because you can't give it to them unless you're allowed to do that, because it's not the right administration. The right drug and the right documentation is important. Now we're going to have some more learning objectives. The next section we're going to talk about is what's the difference between a medication that's a local or a systemic medication. So we'll give examples of those. We're also going to talk about different forms of administration. We've already talked about a few of them, but in regards to local and systemic effects. And we're going to talk about the beginning skills in pouring medications. You may or may not be aware, as there is some guidelines for liquid medications. So the first thing we're going to talk about is the two main effects of drug administration. Now, this is not how we administrate it per se, is what it does to the body, right? And those two are local and systemic. So with local, that is going to be the intent of a local type effect is that it only works on that site of application. So for me, the way I remember this, the most common thing I can think of is putting a cortisone cream on a rash, right? So that cortisone cream on that rash is only going to affect that area that it's been applied to. That's local. And local is a term, a medical term, that usually, as you use it, means just that. It's limited to this area. So if you give them a local analgesic, so pain pill for this area, if you're going to give them an injection of xylocaine to numb an area so that you can do a procedure like stitches, it's local, right? So it's just this area is being affected. Whereas systemic is going to go throughout the body. Now, does it go throughout the entire body? Sometimes not, but for the most part, yes. The entire body could be affected. It's systemic, meaning the whole system. That's how I remember it. It could be a general effect that it's absorbed into the body. So you put that on a certain area, the body absorbs it, but it affects the entire body. A great example of that is the nitro paste that I talked about earlier. It's not local. It's applied like a local, like that cortisone cream would be applied to. And they can even have pre-made applications for things like a cortisone, where it's put there and then it can't move around, because you really want that one area to get the dose. Or it could be like the nitro paste that's on a pre-measured application, and it goes through the skin and it affects the entire vascular system. So it goes systemic throughout the whole body. Just a little note, okay, a side note, that if something is going to affect the entire vascular system, the bones or the skin, then it is considered systemic. So to say, well, this is going to go in and only affect the bones. That's it, only the bones. But the bones are systemic throughout the whole body, right? So if it's applied here, now I can't think of anything that absorbs into the bones like that, but let's say it's applied here, but it's only going to affect the bones. The fact is it's going to affect the bones here, it's going to affect the bones here, it's going to affect the bones here and your toes, the entire, skeletal system. If it is a vasodilator like nitro paste, it is going to affect the vascular system throughout the entire body. You get a splitting headache, even though it's only applied right here, right? It's systemic, goes throughout the whole system. So just as a side note, if it is an organ or a body system that affects the entire body, like the skin, the vascular system, the nervous system, or the bones, the skeletal system, then again, it would be something considered systemic. Okay. Also, you could have a medication that's only local or systemic in the effect, and some medications have both. Right? They work locally, but they're absorbed throughout the whole body. But the purpose of why it's being used is for this one local area, but it in fact is absorbed through the whole system. That is possible. What is the administration for local effects? Now, I already gave you the example of the cortisone cream. That's the one that I think of the most. Remember, what is it, Biactin? Is it called Biactin, I think? That spray that they used to have, and I remember I liked that smell, and that you skinned your knee, you'd go to the school nurse, and they would spray that stuff on your knee, and it would kind of numb it. It would be an antiseptic, but it had a little numbing agent in it, and it was local, right? It didn't go in throughout the whole body system. It has a desired effect that's usually immediate, right? You sprayed on that little skinned knee, and it soothed it. It was cool, and gave you pain relief immediately. But you do have to be careful, because you can have a toxic effect that can result from an undesired systemic absorption from a local site. Now, when we say toxic effect, that doesn't always mean that everybody would have the same effect. Okay, a toxic effect would also be an effect of a person who's allergic to something, right? Let's say my mother-in-law is allergic to everything that ends in cane. Okay, which, can you imagine anything that? So cane, anything that ends in cane in the pharmaceutical world usually is medication that deadens and numbs. Xylocaine, lidocaine. They also have certain types of injections that they give you when you have a heart attack that end in cane. But her body is really sensitive to that. So if she were to get an injection for a local injection of lidocaine, because she needed to be sutured here, her whole body would start to swell. She's very allergic to it, right? It's so bad that her eardrops that she would use for her, because she's deaf and she had some things with her ears, she could no longer use them because they had a numbing agent in them that was a little lidocaine or something, and that she'd put a couple drops in there, and then within minutes the whole side of her face would swell up. And so again, local effect, but it did have a toxic effect, an undesired systemic absorption. So that would be an example from a local site. It doesn't always have to be an allergic reaction still. Note that if you have intact skin, usually things are impermeable. So, if we have we put something on our skin like Benadryl. Benadryl is an antihistamine that liquid Benadryl, you need to drink it, right? But if you were just to take Benadryl, put it on a cotton ball and put it on your arm, it is not going to work as an antihistamine systemically through your body. Your skin is intact, and it is pretty much impermeable to most agents. Now, do they have Benadryl cream that they use for allergic dermatitis and things like that? Yeah, they do. It's got Benadryl in it, and yes, it's kind of a topical, it soothes, but it isn't something that goes into the skin systemically. Ointments, and again, there's a difference between ointments and creams. All right, we've talked about that in other lectures in more depth in this course. But let's say you have an ointment that has an anti-inflammatory or an antibiotic agent. They work really well for local effects that won't go systemic. Whereas most antibiotics, if you take them orally, it's systemic, right? It goes through the system. So again, keep that in mind when we talk about putting anything on the skin. Note that they mention newborns. Newborns are different because their skin is very permeable, right? When the baby comes out, they think about that. They have been encased in a body of water for 9 months. And their skin is very permeable because not only do they absorb nutrients through the umbilical cord, but that floating in that fluid, that special fluid also you can put medications and medication. It's permeable. It's like osmosis, can go through the tissue. And the older you get, the more impermeable your skin gets. Not meaning if you're 50 versus 12. I'm saying newborns, their skin toughens up quickly, but you're not going to put something on a newborn's skin. You'll be very careful. The mucosous membranes, that would be inside your mouth, inside your nose, vaginal, rectal. Those are all areas that have mucosous membranes. What makes them different than, say, your skin is they have a very high fluid content or water content. All right, so they makes them permeable more so. So if you put something in your mouth, right, it's going to permeate and go through the mucosous membranes, whereas if you put it on the top of your hand, on your skin, the dermis isn't going to have that same permeability because, again, the fluid in and out of those mucosous membranes. Oh, also the eye. I didn't mention the eyes because that's permeable. So those membranes are more permeable than the skin. Keep in mind also that you can have something that is intended to be local, but can have a systemic effect. A perfect example of that, let's go back to the nitro. You have the nitro paste that can be put in the skin, but the little nitroglycerin pill that's put under the tongue and given sublingually under the tongue. Sub means under, lingual means tongue. It is meant to touch the mucosous membranes under the tongue. It's absorbed into the body. They tell you if it doesn't have a little sting or a little bite to it, a little sizzle, then it's not working because it's nitro. And but it's a systemic effect. It's not a local effect, it's a systemic effect. It's going to go out throughout the body, just like if you were to put the nitro paste on your arm, it would go throughout the whole body. Suppositories, they have both local and systemic effects depending on what you're giving them. So let's say a person needs a suppository for rectal hemorrhoids. So we need an anti-inflammatory type medication that's local for that mucosous membranes in the vascular system that is swollen and irritated in that one area. And the suppository, the medication will melt in the little waxy substance that it's put in, and then it will be like a topical, although it's inside the body, and it will work locally. Versus if a person's got nausea and vomiting and they give them Phenagrin suppositories, which would go through the body systemically, right? So they can't swallow a pill because everything that goes into their stomach just comes right back up, right? So and we want them to stop the nausea and vomiting, and Phenergan does that. So we would give them a Phenergan suppository, which would be absorbed through the mucosal membranes of the rectal tissue, and then it would go systemic through the body and would calm the stomach, and hopefully that they would not have nausea and they would not throw up anymore. Okay, so again, depending on what the drug is, suppositories could be local or systemic. In addition, you have vaginal routes. There are hormones that can be used in vaginal suppositories that would be systemic, or you might have something like a boric acid type substance that's given in a vaginal suppository to help with a yeast infection that would have other medications in it. That would be a localized, would only affect the surrounding areas. Enemas, much like a suppository in the fact that we're inserting something from a natural opening into the body, the still mucosal membranes in that area, but pretty much you only give somebody an enema if you're trying to get a laxative effect. So we're wanting to clean out the colon, the rectum, maybe there's an impaction or the person hasn't been able to get the stimulation for a bowel movement, right? And again, there are other rare cases, but enemas, that's the purpose of them for the most part. They have different types of enemas. They have oil-based, they have suds, they call them soap suds enemas, and they have regular water enemas. Again, it really depends what's the purpose of maybe if it's an impaction versus we just want to stimulate the body can't get that maybe the vagus nerve or whatever to kick in to help the person have a bowel movement. Intranasal medications. This is almost always just a local. So we give a medication intranasally for the most part because the patient is congested, right? And we're going to administer it through the nares, which is your nostrils, and get into those mucosal membranes in the sinuses. Be very careful with a lot of those medications because some of them, especially the over-the-counter ones, are extremely addictive. What happens is the mucosal membrane, it will literally close itself up and tighten up even though there's no more irritation just to get more of the medication. Extremely addictive. That's why they say don't ever use them more than 3 days and maybe 4 days, but I think it's 3 days. And what's really difficult to do is usually that third day is horrible bad because the body says, hey, this worked great. I want more of it. So I'm just going to shut everything down, swell it all up until you give me more. Kind of crazy, but it's the truth. For the most part, again, intranasal is used that way. You can treat asthma via intranasally. There are some medications that can be used for that. However, there's some that are for allergies like, oh, what's the name of it? An allergy medication comes in the green bottle. It's now over the counter, and you use it once a day, and it is local, for the nasal passages, but it is an allergy medication that you're putting into your nose. A lot of asthma medications are inhalants through the, going straight into the lungs from the mouth, but intranasally, they're again, congestion. Just a note here that that's a good point that they tell you, when you use a nasal application, you don't shove it way up in the nose, and you always want to clean them off afterwards because you're going to use them again and again. And if you do have some type of an irritant or something, a virus or something going on, you want that to be clean because you're going to stick it back up in your nose and reinfect yourself. Ophthalmic medications. This is another area that is very sensitive and prone to getting infection if you have things exposed. Be very careful about dropping drops into the eye, you want them to be, you want your eye to be open. It doesn't matter where you put it in, like usually the sclera, the white part of the eye, and you drop it into the eye, okay? Versus taking the little point and shoving it into the corner of your eye and squeezing it. That's not proper administration for an ophthalmic medication. You're contaminating the administration source. Also, we tend to not pay attention for both intranasal and ophthalmic, but especially ophthalmic. Check those expiration dates. The content of them are very degradable. And so an expiration date could mean that there's bacteria built up or something in there that shouldn't be there, right? There's preservatives and stuff in there to try to maintain it. We also have ear. If you go to put something in the ear, it was really interesting because I never thought about this until I had read it preparing for the slides, that for an adult, you pull up on the ear and back, but on a child, you pull down and back. So for an adult, you grab the top of the ear and pull it back, but a child, you pull the earlobe down and back to straighten out that canal a little bit to get clearance, I guess you could say. When you're working with putting anything in the ear, the protocol is usually that you have the patient lay down and you open up the passage, like you said, adult or child, you put your drops in, and then you have them sit there for a little while for that to go down into the passage, and then let it absorb, right? Because if you immediately get up or turn your head, that liquid will just drain out, and you don't want that to, you want it to seep into the tissues. Going back from local to systemic effects, really a lot of this has to do with the drug that's being administered. It's absorbed into the blood and carried throughout the rest of the system that way, okay, to the different organs and tissues. Like the nitro paste, it's so easy to explain the nitro paste. But let's talk about medication that's given via patch to help someone stop smoking, right? That's a little bit different, but we want it goes through the blood system and into the organs and works on the body. It works on the brain to stop the craving for the nicotine. There are several types of systemic administrations. We have oral, sublingual. This is a funny word, and I always say it wrong, but I went and listened to the way they say it because you put the emphasis in the wrong place, in my opinion. But it's not parenteral, it's parenteral. And I went ahead and put a little definition there for you. Administration or occurring elsewhere in the body other than the mouth and alimentary canals. So ultimately, this, for the most part, this means you're being injected with something, a syringe, right? Inhalation and topical. Those are how we're going to administer something that we want to go systemic into the body, go throughout all of the body. So if we're doing systemic oral administration, again, they're going to swallow it, right? The patient swallows the medication, and then it has to dissolve into the stomach, and then it usually is not, it still has to go into the intestines, and then it goes throughout the body because the intestines are what does the absorption. The stomach breaks things down. So they're honestly very convenient, right? To give an oral medication and you're good to go. There are some disadvantages. One is that it's slower, and slower than maybe even not usually slower than a topical, but it really depends what the medication is and what the purpose of it is, and as well as slower than an injection, because if you give somebody an injection, it immediately absorbs into the body, whereas a pill has to go into the stomach and then it's absorbed through the intestines, right? And you got a little bit of time lapse there. And if somebody has a stomach that is underactive, right, doesn't produce as much gastric juices, which happens when we get older, it's going to take a little bit longer for the body to absorb it if you take an oral medication. It's really nice, though, that you can do a tablet, a capsule, or liquid with oral administration, and you can do liquid gels. I know that my sister, for example, if she takes ibuprofen, she gets the liquid gel. She says it costs her a little bit more, but she gets better relief than if she takes a tablet or a capsule. And she said, I don't know, I've used it again and again for the same type of pain. The liquid gels for her works the best, and so that's what she always gets. And then, so it's nice that you have those abilities to take different forms that work for you. Also, we consider taste. Sometimes if you've ever had to take a medication that was extremely bitter, if a person has problems swallowing, that could be a disadvantage, right? Some of those pills are pretty nasty tasting. I have one that doesn't taste good, but it's a pretty small pill. It goes down very well. But if you ever get it stuck at the back of your throat and it doesn't go down well, oh, I know we've all done that, right? My son, one of his medications that he had to take for his seizures didn't taste good. And he used to always make this horrible face. But then again, he's been taking oral medication since he was, I think 5 is when he started swallowing pills. And so now he's 13. He can swallow pills like an expert. Sometimes they'll, if you're able to take the medication with juice, that'll help. But some juices, like orange juice, can't be taken with certain medications. But you never crush a medication unless you're given permission in the written order to do so, because for the most part, medications can't be crushed. They're not intended to be crushed, or because they may be time released. Maybe there's a protective coat, especially anything that has a protective coating around it. Or if you look at a capsule and it has different colored little pebbles in it, that's usually a sign that something sustained released in there. You never crush that. Okay, moving on. It's very important to note, and we'll say this more than once probably, that some medications cannot be given orally, no matter what. And insulin is a perfect example of that. It does not survive the gastric contents of the stomach. So that's why you'll never see insulin in oral administration form, whether it be a pill or anything else like that. Okay, insulin does not survive the stomach. That's why insulin's always given in an injection. Now, they do have medication for diabetics that are glucose medication, but it's not insulin. Okay, insulin has to be injected, or it has to go into the body some way that it doesn't go into the stomach. When you have some medications, they can be affected by other things that you ingest, like tetracycline and milk. Don't mix. Milk will make tetracycline not be effective. And then also some medications can upset your stomach. Ibuprofen, NSAIDs, very classic for upsetting the stomach. So they always tell you that if you've got to take an NSAID, which is like ibuprofen, then you need to eat something with it, eat a little something. No, people that have had gastric surgeries usually never get to take NSAIDs again. So I have to be in a lot of pain for me to take an ibuprofen. Tylenol doesn't usually work with pain for me, neither does aspirin. But because I'd always used ibuprofen, and now that I have very little stomach left, I would never take an ibuprofen unless I absolutely felt like I had to. I would only take one, whereas before I would take 4 at a time. And the times that I have broken down and taken one usually results in severe heartburn. And then I end up with a week or 2 on Prevacid or Prilosec to try to calm that down. So again, some medications upset the stomach, and for various reasons. Also, there are some medications that absolutely need to be taken with food, and they'll be labeled on the prescription from the pharmacist. Always just standard protocol, tell people to drink a glass of water, a full glass of water, which is considered 8 ounces. right, with any medication. I used to be very bad about this, but even if you can swallow the medication on the first sip, go ahead, and that allows it to pass through the stomach quicker and get into the intestines and absorbed into the body. Do not take medications with alcohol. So don't take your blood pressure pill with a beer or a glass of wine. What happens is alcohol ends up working like a solvent, right? And it will break down the medication. It can also prevent absorption. There are several vitamins, minerals. Be very careful with health supplements. You know, if you take something that is an herb or a vitamin, even if it's a multi-day vitamin, you need to let your pharmacist know, and you need to be aware of, if you're administering a medication, that, you know, hey, I take vitamin D, and they just put me on this blood pressure pill. It's not going to be a problem, because if you don't tell the provider, you don't tell the pharmacist, they're probably not going to label or know that you're taking that, right? And it can definitely affect not only drug absorption, but interfering with the medication and making it not work, or making something work to the extreme. Always read all the instructions, and you really shouldn't take medications with hot liquids. So don't take your blood thinner with, don't take your Coumadin with your coffee. It's not a good idea. Again, that is like drinking alcohol with it. It just affects it. So I made this little chart, and I know it's a little messed up here because I had to add it on there. Ask yourself, are you aware of different herbal substances that work with, that interact with antidepressants, for example? So the herbal drug, we've got ginkgo biloba, St. John's wort, and ephedrine, and ginseng. Those all definitely have an effect. What do they interact with? Ginkgo biloba, do not use that with aspirin, warfarin. These are all blood thinners. Plavix, and just be very careful. So if you are on aspirin therapy, you're not going to be taking ginkgo biloba. Also, St. John's wort is a blood thinner, right? So you're not going to be taking St. John's wort with Coumadin. There's people that have died doing that, bled out. St. John's wort, for the most part, is used as a natural antidepressant. So you're not going to also take St. John's wort with antidepressants. You can have reactions, but a lot of people aren't aware of this, that it is a blood thinner. Ephedrine hypes you up, right? It's like natural speed. Well, that means you're not going to take it with caffeine. You're not going to take it with decongestants, because that's usually how decongestants work. And any type of stimulants like no-dose. You remember those little packets of no-dose to keep you awake, which I think is mostly just caffeine. Ginseng you don't take with warfarin. Oh, wait, no. I think that's supposed to be warfarin and not that says warfarin. That's not really a thing. But that R is supposed to be an F. So you'll have to pencil that in. Again, don't take a ginseng with any type of blood thinner. Doesn't react well. Now we're going to discuss pouring administrations, oral medications. There are some things that are basic. Of course, wash your hands. You always do the routine. Identify your patient. They'll say the name and also the birth date. Look at the drug label. Make sure that it matches either your Cardex or your electronic medical record. If you pour pills, tablets, or capsules, before you administer them or put them in the little cup to give them to the patient, you put them in the lid, right? That's the proper procedure. You pour out 2, you look at them in the lid, and then you pour them in the little administration cup, and you don't touch them. right? And I don't know if you've ever been in a hospital, you can see that they'll, they try really hard not to touch them, but things happen and they'll pick them up. They'll either hand them to you in the little cup, or you'll put your hand out and they'll put them into your hand from the little cup without touching them. You don't touch it. If you pour liquids, you pour away from the label. Did you know that? Basic procedures, because you don't want anything dripping on the label and preventing you from visualizing the label. Also, you always wipe from the neck down when you go to put the cap back on. That's also because you want the germs to go away, push them away from the cap. Lost my mouse. More in the proper way to pour liquid medications. If you are going to use medication glass, they call them a graduates, then you're going to always do it at eye level. You're going to hold it up, use it at eye level. You put your thumb at where you want it. So if it's supposed to be at 1.5, you hold it at 1.5. So you're holding it, you put your thumb at 1.5, and so that when you pour the contents, your thumb is the marker for yourself. And then also, if you're using a glass or a graduate, you can decide what am I using. Okay, if I'm going to use anything over 5 mils, then again, you would use a graduate or a glass. The graduate's the tall, skinny thing. And the reason is it holds more content versus the syringe, the dosing syringe. But otherwise, you would use a dosing syringe if it's anything below 5 mils. Sometimes you have to give more than one medication to a patient, so you always give tablets or capsules with water, right? Or they can have juice, whatever they. If you give liquids, you might have to dilute with water, and then sublingual would be third. So you give them last. So if they're supposed to take 2 pills, right, and then they're going to get 1 ounce of another liquid medication, you give that second, and then if they need a sublingual tablet, that goes last. That's just pretty basic protocol in the administration of medications, more than one medication. And you stay with the patient until you visually watch them take the medication. You don't walk away until it's done, right? So even if the patient, you give them the medication, you put the little cup down on their stand, and then they say, hey, I need to go to the bathroom. Then you either have them take the medication before they go to the bathroom, you help them to the bathroom, you stay until they take the medication, because they don't want them to forget that dose. Because not only are you responsible for administering the correct amount of the medication at the right time, you're responsible for confirming that they actually took it. Right? When you record that the patient has taken the medication, you only record after it's actually been given. Because there are scenarios where you go in and you say, okay, I'm giving my patient their, antibiotic, and you get in there and something happens, they go to the bathroom, you set it there, then again, you walk away and they've missed that dose because you didn't watch them, and they knock it off the counter, or they cover it up with their meal tray. The next shift comes in, the meal tray's taken out, and there's their antibiotic dose from that morning from breakfast that they should have had. Messes everything up. So you do not literally put in either the Cordex, which again we don't use too much, but electronically, that you've given the medication until it's actually been administered, and you watch them take it if it's something oral. If they don't take it, you've got to administer that they didn't. You've got to document that they didn't take it and why they didn't take it. We continue on with dose packets. Sometimes the medication, it comes down from the pharmacy at a facility or different areas, home health was very common to have dose packets. You can have single dose, and they'll already have it dosed out for however you're supposed to give it to them. This could happen if it's a liquid. This could happen if it's an injection or pills. So if they need to take 3 pills at one time, in that little bubble pack, there's 3 pills ready to go. It also is always labeled. They'll either have, well, they probably will always have the generic and the name brand, which would be the trade name. So let's say we're doing Tylenol again. So it would say acetaminophen 500 milligrams, which is Tylenol 500 milligrams. It was packaged on, 1/1 whatever year, and it expires on 1/1 whatever year. Okay, that will be labeled on everything when it comes down from the pharmacy if you're in a facility. They may have a barcode where you can just scan it and everything is put into the system for you. This is extremely helpful, those scanning systems, when you have narcotics that have to be administered. When you had to do that by hand in the past, everything had to be counted at the end of the shift, right? And there's still, may have to be counted, but when they first started doing electronic stuff, it was the narcotics that got scanned. And if you were giving them an antibiotic, it didn't have the ability to be scanned. But narcotics are controlled for a reason. And and always be careful with hand contamination. Let's see. Oh, I already mentioned that if you're going to give liquid medication that is over 5 mils, then you would use a graduate or the glass. But if it's under 5, then you'll use an oral syringe, because you're able to get the proper dose with an oral syringe. You wouldn't like pour it into a cap. It's not the proper strength. You would pull it up with the oral syringe, and you would either give it to them with the oral syringe, or you would push that out into the little cup and have them take the cup that way, especially with young children. Some medications are administered that can have systemic effects, toxic effects. Just a little highlight in the notes that I was given, things like boric acid. Boric acid, I think, had been used in the eyes a lot, but a long, long time ago. But they also do use boric acid to get rid of yeasts. And methyl salicylate is used for topical, usually for sore muscles. So things that have like absorbing junior biofreeze stuff would have methyl salicylate in it. And salicylate is a type of analgesic, like aspirin is a type of salicylate. And then hexachlorophene, that is what was that one? I'll have to remember what hexachlorophene was used for. I think hexachlorophene had something to do with the mucosal membranes, but I'll have to, well, that would be a good thing for you to study, because this was just extra content that I wanted to add for you. Go look up and see what hexachlorophene is. I think it's a pain, it might have been a pain reliever, because hexa is the shape, and chlora and phene is, you always know because it's PHENE, means something specific. If you know what hexachlorophene is, you can put it in the chat, or better yet, put it in the CCO club and share with everybody. But they can have systemic effects if they're applied in the wrong area, right? And given the wrong amount. Be very careful with package inserts on medications and any toxic effects that you need to be aware of. And there's a lot of information on those. You have to unfold that little card and that paper, and it's like tissue paper, and it's very long. But especially if it's a medication that you're not familiar with, then it's protocol that you read that and look at that. When we look at sublingual administration, I already mentioned the nitro pills, and something about that is that they're always stored in glass, and they're always stored in amber glass, and that's because the sun light makes them lose their value, their ability to work. And you do not swallow sublingual medications. So if you are administering even something over the counter that is intended for it to dissolve in the mouth, don't swallow it. That's not the way it was intended for use. It's supposed to go into the mucosal membranes, that under the patient's tongue. And then it may not work if you take it orally. So it may hit this acid in the stomach, and then it ruins it, and you don't get the effect that you need. But the most common medication that is a prescription is nitroglycerin, nitro pills. Be aware, we'll mention newborns again, they are actually at a higher risk of toxicity from local medications. Again, we already talked about their skin being more permeable. And if you're ever in doubt about anything in administering to an infant, you query the provider and make sure that you have a full understanding. If you even think that something is a little off, be very careful. The last section, the learning objectives that we're going to talk about, we're going to talk more in depth of the parenteral administration, which is like injections. We're going to talk about examples and how things are injected, the different types we have, subcutaneous, intramuscular, things like that. Disadvantages to giving drugs this way and advantages versus oral. And we're going to talk about calibrating when we do intravenous solutions. We're going to do an IV. So if we're going to do administration, just a little recap of things, you need to ask yourself, what effect is the drug going to have on the bloodstream when it's absorbed? So what is the route of administration? Like food, right? So what is the when it gets into the bloodstream, what is the effects? You know, ask yourself that. Also, what's an example of oral medication? Again, we already talked about acetaminophen is the one that I keep using, but anything that you swallow, right? And then sublingual, the number one you ask yourself would be a sublingual medication, nitroglycerin would be. And some medications are created to be sublingual because the person isn't able to swallow a pill for whatever reason. Ask yourself also, what's an example of a rectal medication? Here they've got, let's see, prochlorperazine, but I use Phenergan, right, as an example. Insulin can only be used as an injection, right? And inhalation, albuterol, right? Perfect. Albuterol is a rescue inhaler for the lungs, predominantly used for asthma. Also, there are some medications that are that work better when you take them with food, especially the examples that they give are iron products. So if you have to take an iron supplement, man, that's harsh on the stomach. I used to think that, oh, my stomach when I was younger and I had to take iron for a little while, I was, my stomach can take anything. Back then it could, but I did that and it tore up my stomach. Erythromycin is an antibiotic, and some of those need to be taken with food. If you can't swallow a pill or a capsule, then you definitely need to let the provider know, because not all medications can be crushed. Some medications can be crushed, and they'll commonly, especially in skilled facilities or home health and stuff, they'll put them in applesauce. That's very common to have a little applesauce there. But again, not all medications can be crushed, and I already went over the things to look for and to note about that, why crushing a medication would be bad. If a medication is scored, and that means it has a line, which I don't know if I can give you an example, just pull one of mine out. If a medication is scored, a lot of times it can be crushed, meaning it could be broken in half. Not always. Don't take that as a given. But if it isn't scored, that's a definite giveaway that, hey, this is not to be crushed. Let's see. When we are doing this type of administration, it's always done with a needle, whether it be intravenously or muscular. It doesn't matter. It will be given with a needle. It is usually the fastest absorbing because when you put something topically on the skin, it has to absorb in the skin to get into the system. But when you put something gastrointestinally, absorbs much faster. You can, though, have some unwanted effects, and it can be fatal because some methods could be hazardous if that effect is injected and it's not supposed to be injected, right? Because it goes into the system too fast. And so, again, like you would never inject nitro into the body. There's always the risk of infection when you have to inject somebody because you're introducing something from the outside on into the protected inside of the body. You could have bleeding. Somebody that's on Coumadin therapy could have bleeding. You could have a hematoma. So if you've ever seen, especially the elderly people that go in and they have had IV or they've had to have injections and they've got massive bruises up and down their arms. That's why sometimes it's painful, not just because it's a needle, but the medication that you inject is painful. A lot of antibiotics that are given in the hip are really painful. We've all had a tetanus shot, and that's like being hit in the arm, right with a bat for a couple days, and it's swollen and hot to the touch. Nerve damage has happened, and you can have tissue damage, usually because of the medication that's being administered, not because you stuck them with a needle. You have to be very careful with the technique. Sterile technique is very different than aseptic technique. Sterile means you're not administering medication via sterile technique if you're giving them a shot for an antibiotic. That's where you got the gloves, the gown, the whole 9 yards, you got the drapes and stuff like that. Now, if you're going to inject somebody with a procedure, yes, that would be different. But an aseptic technique is meaning that you're cleaning the area. The needle is sterile. You inject them and then you get rid of it, right? There's a difference between aseptic and sterile technique. Drugs given this way usually have a vial with a rubber stopper, and then so that the medication cannot come out of the bottle. A lot of times, once you inject it and you pull out the medication, you don't use that vial again, right? Now sometimes you do, like insulin, right? So it has a little rubber stopper that would seal up, after you inject it, and then you have like 10 mils of insulin, and you're going to use 2 cc's every day or whatever. So it would last several days. You have ampules. Now, for the most part, vials are not plastic for the most part. They're glass, but not always. There are some that are plastic. Glass ampules look like a little tube with a little knob on top, and you snap that off, and then you can draw up the syringe. There are some that are powder, and you have to reconstitute them. So they'd have a little vial that had powder in the bottom of it, and it tells you to put in, however, 5 cc's, and you would inject you would draw up 5 cc's of the liquid that you're going to use. You inject it into the vial, you shake it up, and then you draw it out, and then you administer it. So it's powdered, and it doesn't kick in and go into effect until it's been reconstituted. There are single dose or multi-dose vials. Insulin would be a multi-dose vial. And we also have pre-filled syringes. So when you have things like flu shots, a lot of times now they come in pre-filled syringes, and they even have the needle attached and everything. So you literally unsnap it, give them the injection, cover it back up, and throw it out. It's all ready to go in individual dosing. There are three types of injections that we give. We give intradermal, subcutaneous, and intramuscular. We're going to talk about those more in depth. If we do intradermal injections, those are things like skin testing, right? TB tests are intradermal, where we're just going under the top of the skin, or we're just breaking the skin and allowing something to touch the skin to see if we've got a reaction. This is going to be a very small, tiny needle, 25 to 27 gauge. It's only 3/8 of an inch. And when you give this injection, it's always at a 10 to 15 degree angle. We've got a graphic of that. Very strong, tiny amount that's going to go in. So when they do the TB test and they lift that right underneath the skin, they're just literally going underneath the skin, and they make a little bubble, right? Very tiny amount. Inner arm, they can do it on the back if you're going to do testing for skin testing for allergies and stuff. If they do a TB test, they always do it right here somewhere. And again, it's just entered right underneath the dermis. Usually what they call is a wheel. They make a circle with it. It makes a little bubble and raised. Think of it as when you know, the bubbles poppers that come when you get a package, you know, a little bubble like that's what they're making. And this is the angle. Again, a tiny little needle, and it's going to go just into the epidermis, just right underneath there into the dermis at an angle. If we do subcutaneous, this is going to go under the skin. We want to hit the fat, usually, or connective tissue, and we're going past the dermis. We usually use a 25 gauge needle. It's a 3/8 or 5/8 inch, and you do this at a 45 or 90 degree angle, depending if you have the thickness or fatty tissue, right? Meaning how much fat does a person have on their body. You know, some of my children have no fat on them. They're all skin and bones, versus me that has a little more cushion, a little more fat. The drug amount, usually when you're administering something subcutaneously, is 0.5 or 1 ml. Always, again, aseptic technique. And this is what that looks like. So we'll be giving that into the arm. Notice here we're getting in the subcutaneous tissue, and we're not doing it this angle. We're doing it more at an angle like this, right? Because if we go straight down, we're going to hit muscle. So let's talk about intramuscular. We want the medication to go directly into the muscle. This is going to be a 19 or 21 up to a 21 gauge. The needle is 1 to 3 inches. We are usually giving up to 4 ml if it's an adult, but it's a lower amount usually with a child or an infant. This is when they're giving those medications and vaccinations into the leg. You'll see them. They go straight down into the fatty part of the leg. And then if they give them in the arm, which a lot of times they don't, you'll notice the angle that they use, 90 degree angle. And whenever you do anything that's going into the muscle, you have to pull back on the syringe or aspirate the syringe. So you inject the person, and you have a technique where you pull back on that from the stopper that comes back, because if you draw back blood, you've hit a vein or an artery or something, and you don't want to inject medication into the vascular system. You want it to go into the muscle. And so you always pull back, you get nothing in return, and then you inject. Okay. So you have to aspirate. It definitely works faster whenever you give something into the muscle. It works faster than subcutaneous. If we're going just right underneath the skin, the idea isn't necessarily to get it into the system. We're wanting to see a reaction, right? But if you're doing intramuscular, we want that to go in fast. And that is going to be either in the deltoid muscle, the vastus lataris, or the gluteus maximus, which everybody likes to say gluteus maximus, which is the largest muscle in the body, and it is your backside. We got a picture of that too. So intramuscular would literally look like this. We're going straight down, and we want to tap into the muscle, but we don't want to get a vein or an artery. We don't want to hit the vascular system, because we're going to draw back before we inject and make sure we have no return from that. Intramuscular, this is going to be upper arm. So you got the large muscle right here, that deltoid muscle right here would be where we would want to give that. And again, there's this the magic triangle when you do that. The thumb, I can't do that on myself because my hand's wrong. That's how they teach you how to inject that. And then the gluteus maximus, which is, they'll say your hip, you know, but really it's not in your hip like on the side, it's in the back. And we want that largest part of the muscle, right? And then again, we can do the vastus lateralis, which is children, which is that little fatty part, or, you know, the biggest part of the muscle in the leg, right? So here's, you know, the knee, and then right behind that, you grab that, pinch that a little bit, and then you go straight in and hit that, hit the muscle. If we do administration of intravenous routes, then again, we do intend to tap the vein there, right? And by far, that is the fastest way to administer anything into the body, right? That is the fastest, so that if we want an antibiotic onboarded even faster, they can give you an injection, but if they want a stronger antibiotic that can't be given into the muscle, they might do it intravenously, or they want to, you know, get it into your system faster. They do any central vein that is close to the surface. So again, I have this great vein right here, which I don't even know if you could even see it, bulge right there in the camera. Also very fast, but you have to be very careful when you start an IV with medications on a patient, because it goes into the system so fast, you're going to see a reaction very quickly, right? Thus, right, when I told you the example of them, just all I was getting was fluids. They hadn't given me any medication or anything yet, but it was glucose was in there, because if you go into labor, you're wearing your, you know, your body's worn out, so they're giving you sugar to give you energy. And just that short time, I mean, she literally put it in, walked out, the other girl came in, and it had already filled my body with sugar. So again, reactions can happen quickly. Let's see, make sure with compatibility of medications that are given, if you're given something oral as well as IV, that happens. Now, you also have to pay attention to the rate that the medication is being given when we do intravenous. And just so you know, that GTT is the abbreviation for drop, okay? So if it's a dot hyphen dot, that's one drop. GTT, not GT, GTT. Okay. If you're going to do an electronic infusion, meaning you put the IV in, you hang it, and then you have a machine that you put the IV tubing through, and then it calibrates and runs it. And you just literally log in what you want it to do, and it makes sure that the medication is given at that proper rate. Then again, or you can do it by gravity, where, you know, you've seen the little thing that rubs the, you can open it wide open. Have you ever heard them wide open? They squeeze the bag, you know, versus you pulling it down where it does one drop. And it's all being done by gravity. You can calibrate the tubing is how it's delivered, and how you calibrate either whether it's electronic or gravity, right? If it's electronic, the machine is preventing the tubing and opening the tubing and preventing the tubing. It literally, you know, you can say, okay, I want this given in 1 hour. I want this given in 3 hours. This is really critical with machines when you're giving chemotherapy, right? So, you know, you may be in there for 6 hours getting chemotherapy, but the first infusions may be things like Benadryl and Zofran, things like that, to compensate the effects of the chemo that they're going to give you. And then that's onboarded first, and then an hour later they onboard the chemo, and then that goes over, say, 3 hours. They want to make sure it's very controlled, not just running that little bar over the tubing. And using gravity. So your calibration, you can do it between 10 to 60 drops a milliliter. That's how that's based. If we do intra-arterial injection, that's even faster than venous, because if you think about it, your venous is peripheral for the most part, deoxygenated. You've got to go through the lungs and then the heart, right? So it's, think of active and inactive blood, I guess, if you want, that's my own term. So inactive blood doesn't have the oxygen in it and stuff, and it's going back up to be recharged, right, with the lungs and stuff. Whereas the after it leaves the lungs and has oxygen, I think of that as active. Again, that's strictly my own brain. But intra-arterial, again, that is powerful. It's the elasticity of the arteries and the pumping of the heart is getting it through the body. Very seldom do you ever administer anything via arteries. If you do, it's mostly via like chemo or adenoplastic agents, which is like chemo medicine, maybe invasive cardiology, where you've got to get something into the system very quickly. Person's having a heart attack, things like that. But they inject straight in to the system. That's maybe they put a, not a port, but they put something into the subclavian artery so that they can administer medication very quickly into the body. We have innovative drug delivery systems. This is all new that's happening. There's biocompatible subcutaneous and intramuscular injectable agents that they've come up with, reticular diethyl symptoms, bioadhesive agents. That means that you can put them on the skin or in the mucosal membranes, and it's literally an adhesive like a Band-Aid. And everything's built into that. Oral delivery with peptides and proteins, being able to administer them. Polymers or tissue engineering is a way to get something into the system. That's really cool that they're doing. Let's see, soluble eyes new drugs. Again, using like a solvent to get into the system, and they have implantable polymer chips. Now we already have implantable devices for things like administration of radiation for prostate cancer, but these aren't that's radiation. That's not necessarily a drug. Now they've got ways that they actually can inject something that's going to stay in an implantable device that's going to release the medication over a long period of time, like the different, there's birth control that can be done like that under the arm. It's amazing some of the things that they can do. And that is it. So let me just look real quick. I have a couple questions. Let's address them. The first one is, as a coder, what resources do you recommend to keeping current on medications, brands, and indications? Drugs.com. I used it constantly. Now, some people say that they didn't like drugs.com as much because they thought maybe it wasn't updated as often, but I found it to be always the most current. But there's other resources. There's even apps that you can get on your phone. I think drugs.com has an app. I may have downloaded that. But especially if you're a risk adjustment coder, man, you got to be on top of this. And so you got to know these drugs. You got to know how they're administered. And so because you're reading all that documentation. So that's the one I prefer. Okay, Mayo Clinic has some good ones, and so does WebMD. Let's see. Oh, there it is. Thank you very much. And okay, hexachlorophene is used as a topical anti-infective antibacterial agent. I kept thinking I will remember what that was, but I just completely drew a blank. Thank you very much. And oh, very good point. Lisa Strickland said, do not mix up eardrops and eye drops. Oh, I can't tell you how many times I've seen that happen working in pharmacies and stuff, especially people coming in. And just so you know, you can put eye drops in your ears, okay, if you had to. That's not going to be harmful to you, to your ears for the most part, because it's usually some type of an antibiotic or whatever. So again, if you were to accidentally put eye drops in your ear, yeah, you're pretty safe. If you were to take eardrops and put them in your eye, that's bad. That's definitely something to irrigate very quickly. And because it's different type, remember, this is mucosa membranes, your eye, your ear's not mucosa membranes, right? It's not even as sensitive as the nasal passages, which are also mucosa membranes, right? So the skin has a waxy, it produces wax, which protects the lining, which means eardrops go in, it is slower, but that tympanic membrane or your eardrum, it can go through that, but it, by far things happen slowly. It's usually drops are for like antihistamine drops or something to stop swelling or stop pain. And usually not necessarily an antibiotic will go in the ear, but they do have them, right? Whereas the eye, oh, that's different. It will be absorbed like glaucoma medication, antibiotic. There is still antihistamine drops that can go in, but they're being absorbed into your system because it's a definitely mucosal membranes there. Can medications have more than one route of administration? Rectally. Think of acetaminophen, oral, right? We can give acetaminophen rectally, rectal suppositories. We can give it liquid, and we can inject it even. I don't think anybody would put it topical. Can you put it topical? You could, but it's going to be extremely slow, right? By the time it goes through the skin. But yeah, the absolutely a lot of medications can be given in more than one way, like nitro paste locally or sublingual. There you go. Of course, you wouldn't inject it. So very good question, having them. All right. If you have any other questions, don't forget you have access to the CCO Club as one of our students. And so you can ask your questions there. You'll have other students as well as myself, the other instructors and the subject matter experts, the coaches. Everybody will be in there to answer your questions. Don't forget also to use that as a way to share anything interesting that you find, right? Because we want to increase our knowledge base. If you find a place that's equivalent to like drugs.com that seems to be very user-friendly, that works for you, or an app, put that in there. We'd really appreciate being able to share that with everybody. Or any articles. Fabulous, right? If you are not one of our students and you just happen to be catching this as a little bonus for something, look into the CCO Club, and you can join even if you're not one of our students. But our students get access to this for even after their course is over, right? And that's it. Happy learning, guys. Enjoy the rest of your day.